Okay, great. I think we're in business. Well, look, first of all, it's terrific to be here. And some of the people I've worked with are on the call as well. I think I saw Nick Hopkinson, Paul Kemp, Mark Griffiths, and possibly many others. And as everyone knows, all of this is a team approach. So, I want to acknowledge my collaborators at the beginning of the talk rather than the end. But what I wanted to make the case was that there is a joined up story in terms of muscle weakness. And because I'm a lung doctor, I'm going to be talking about chronic obstructive pulmonary disease, which is the most common lung disease in adults. But I think many of the learnings are applicable to any chronic disease. Let's go on. So chronic obstructive pulmonary disease is characterized by destruction of the lung tissue. That normally occurs as a result of cigarette smoking, but there are other causes. And you might ask, in fact, my lung colleagues frequently ask why we're interested in muscle. But the reason is this, and this is a study that pooled several very large studies. So there are about 14,000 people in this graph from memory. And what it shows is the effect of a bronchodilator on walking distance. And these drugs are very widely prescribed. Anyone who's got asthma, which probably statistically someone on this call probably has an inhaler, and they're very widely used for COPD as well. But you can see they are of zero value in extending your walking distance if you look at the right-hand side of that graph. And the reason that they're so widely prescribed is that in order to get a labeling claim from the FDA for COPD, you have to show that you improve lung function, which these drugs do, but it overlooks the fact that they don't change the patient experience in terms of walking distance. And this is the relationship between FEV1, which is the blowing test that we normally use to diagnose COPD, and the SGRQ is a disease-specific instrument of quality of life related to COPD. And I think probably this was originally reported as a positive result, but as we can all see, it much more resembles the sky at night. And so what's clear is that although it's a lung disease, the degree of lung disease doesn't really affect how the patient feels, and changing the degree of lung disease doesn't help the patient walk any further. And as a consequence, in the field, people have started to think about what we call treatable traits, and inevitably being academics, it's dressed up in a very complicated way. But broadly speaking, we think a clinical trait should be clinically relevant, because there's no point measuring something that's not relevant. It should be measurable, and this comes back to what we were discussing earlier in relation to the glioblastoma, and ideally it should be treatable. And I want to make the case to you in COPD that we are probably at that stage. So first of all, is it something you can measure? Well, these are data from Paul Kemp's laboratory, gathered by a previous fellow, Dr. Satyapala, and there's no doubt that muscle disease occurs in patients with COPD. So the left-hand biopsy is a biopsy from a normal subject, the right-hand biopsy is a biopsy from somebody with COPD, and you will see that there are many more green fibers. These are type 2 fibers, and I'm assuming everyone on the call knows what a type 2 fiber is in the COPD patient. And if you look at these in bulk, which is what Dr. Satyapala or Matanakash was then did, you can see if you look at the top 3 panels that patients with COPD, whilst there's substantial overlap, have fewer type 1 fibers and more type 2 fibers. And that's a pattern that's seen in other chronic diseases too. Each of these dots, by the way, represents an individual muscle biopsy, so it was a heroic effort on behalf of Dr. Satyapala. We also find that muscle goes to fat, and if you do NMR spectroscopy, you see that the involved muscles have got a tendency to anaerobic metabolism if you look at them in the NMR scanner. But it does come to those colleagues who are doing artificial intelligence approaches, it raises a very important question about what muscle you study, because these changes were evident in the quadriceps, which is the main muscle that's involved in COPD, but not, for example, in the biceps. So if you had an algorithm that looked at the biceps, you would find absolutely nothing. Why is anaerobic metabolism a problem? That's a much younger me, by the way. The problem is that the acid is buffered by CO2, and if you've also got lung disease, you can't get rid of the CO2. And patients with COPD actually do become acidotic when they walk if they've got advanced disease. Why does the myopathy occur? Many suggestions for this, and we've published on several of them. Because I've only got half an hour, I'm not going to go into which of these things it is, but we do believe it's probably disuse, and there are some reasons for that. And as I shall show you, this may even be an adaptation of a evolutionary virtue. The reason we think it's disuse is, number one, we know that COPD patients are inactive, and there's a great deal of interest in the field now in measuring physical activity using step counters. We know that the weakness disproportionately affects the lower limb muscles, and clearly if you're not walking about, you will get possible muscle atrophy. Whereas if you look at the hand muscles, and particularly if you look at the expiratory muscles, which I'm showing you in this panel, there's no evidence of muscle weakness. And of course, the reason for that is that patients with COPD continue to use their hands for day-to-day tasks, and they continue to cough. And actually, if you look at it, although it's not significant, the cough pressures were fractionally higher in COPD patients than the elderly controls. This is data that Alison Stubbings got from patients studies with us, but in Mike Ferenzi's laboratory. I think Mike's no longer with us, but again, what you can see here are normal subjects on the left and patients on the right, and these are diaphragm biopsies that were gathered during thoracic surgical procedures undertaken obviously for other reasons. And you can see that in COPD patients, we see the exact reverse of what we see in the quadriceps. So we see a predominance of type 1 fibers, and if you look at the numbers which are in the top two panels, you can see that the degree of that fiber shift relates to the severity of lung disease. So muscle is, as everyone on this call probably knows, is extremely plastic. Paul Kemp and Mark Griffiths gave this a lot of thought. Paul is on the call. I remember him taking a long time to write this review because it's so complicated, and no doubt he'll talk to you about that, but I am a clinician, so I had to keep it simple. And this is the way that I visualized it. And we wanted to put this in the paper actually, but the journal wouldn't let us. So if you think about Stone Age man, he gets injured or ill or has some other problem, and the muscle is then used up to fight the illness, whatever it happens to be. And if it's successful, the muscle regenerates, but if it's unsuccessful, the man dies. Whereas this is the chronic disease paradigm, really, and this occurs, as I say, in several diseases, including intensive care. But chronic illness, we think the patient gets to a stage where they don't die, but they're still using their muscle to fight the illness, and as a consequence, they have physical frailty, which is what is related to medical to healthcare usage. So I hope I've convinced you that muscle disease occurs in COPD. The next question is, how do we identify it? And this is relevant to the discussion that was happening earlier. So clinicians for a long time have recognised the bloke on the right, which doesn't require an enormous amount of clinical acumen, but they somehow imagined that they went from the position on the left to the position on the right by some sort of miraculous, teleporting or whatever. Whereas in fact, of course, it's a gradual process. So various techniques have been developed to measure the quadriceps in patients with COPD. And on the left, you see the isometric leg strength, which is the classical way of doing a quadriceps strength. And on the right, you see ultrasound, which we have found very appealing because it can be done at the bedside and it doesn't require any form of ionizing radiation. And in studies from our group, when we did this, you will see that whether you look at size, which is on the left-hand panel, the ultrasound cross-sectional area, or strength, which is in the right-hand panel, you can see that patients with COPD, and I'll come on to the gold stage in a minute, but you can see that patients with COPD in both cases are weaker and have smaller muscles than controls. But what is also apparent is that there's not really a big progression from gold stage 1, which is the most mild stage of COPD, patients who typically, for example, wouldn't even require an inhaler, to gold stage 4, which is the most severe type of COPD. But all of them a big difference from controls. Now, Will Mann, who may be on the call, who's also in our group, he's a consultant out at Harefield. He was the first one to click that there are simple ways of doing this, and so he identified the short physical performance battery. And I saw from the chat thread there are 1 or 2 geriatricians on the call, but this is a simple test that requires no equipment at all. So the first test is a balance test, a little bit like the old comedy films when the police tries to breathalyze you. You have to see whether you can stand with your feet side by side and then one in front of the other. The second is a gait speed test, and you simply ask the patient to walk between 2 bits of tape on the floor that are 4 meters apart. And the third is a chair stand test. And if you do all that, you get a score out of 12. And what one of Paul and my former students found was that the SPP score, don't forget a low score is bad, did have a relationship with the myopathy that I showed you earlier. Again, obviously overlap, but on average, people with a low score had more type 2 fibers and evidence of myopathy. We also found that the SPBB score related to walking distance, and it related to strength and to the size of the muscle and indeed daily physical activity. So all of that entirely consistent with our thesis that disuse is contributing to this. In a subsequent study, we wanted to see how reproducible this was in a multi-center study, really as a prelude to doing some interventional trials. And so what you're seeing here is about 700 people in whom the SPPB has been measured. And you're seeing the distribution of scores in the top left-hand panel. And then you're seeing the 3 components, the sit-to-stand in the top right-hand panel, the balance in the bottom right-hand panel, and the 4-meter gait speed in the left-hand panel. And you can see that the sit-to-stand test is the most, if you like, discriminatory. It's the one that has the most variance through the COPD population. What we were also able to show from this cohort is that the SPPB is directly relevant to the likelihood of being hospitalized over the subsequent 4 or 5 years. So coming back to this general idea that that frailty takes you into hospital, although we may need to look at that the other way around. But what you're seeing here is if you achieve 12 points, which is the maximum, and don't forget this test has a ceiling effect, that's the top green line, and you're less likely to be admitted to hospital over the subsequent 4 to 5 years. So I hope you'd agree that the muscle weakness can now be identified using a simple test that can be done literally anywhere. So the next question is it relevant? Now, this is back to Dr. Satyapala's work, and you can see that the patient's exercise performance, that's graph A and D, whether you measure it using a 6-minute walk test or a cardiopulmonary exercise test, does relate to whether or not they have a myopathy. So the more type 1 fibers you have, in other words, the fewer type 2 fibers you have, the better your exercise performance. It also relates to the risk of death. This was a very early study from our group. You see on the left Kaplan-Meier survival curves for patients who have normal quadriceps strength and people who have reduced quadriceps strength in the dotted line. And you can see that the survival of those patients over a 4-year period compares unfavorably to many solid organ tumors. So I often wheel out this graph to make the point that COPD actually is a really serious condition. Is it treatable? Well, this is the paper I showed you at the start, which assessed the effect of bronchodilators we looked at 14,000, but in terms of treatment, there were almost 5,000 participants. So it's a pretty large study, and it was a unique effort, by the way, of the industry to bring together studies that had not previously been combined, and at least in chest medicine, that did represent a new openness in the community. And I've shown you the graph. We know that bronchodilators don't improve walking distance. On the other hand, and bear in mind there were 5,000 participants in the previous study, this is a study in which 62 patients were randomized to receive exercise training or not, and you can see that after training, there's a significant improvement in the strength of the quadriceps muscle, about 20%, and that is associated with a change in the 6-minute walking distance of 52 meters, which exceeds the minimal clinically important difference, at least in COPD. But no change note in the lung function. This is a similar study that's done around the same time by the late Tim Griffiths. He randomized 200 patients to receive outpatient pulmonary rehabilitation. Again, by drug company standards, a tiny study, just 200 participants, but highly significant reductions in hospital occupancy and highly significant improvement in walking distance. So are there any medicines for this? Well, look, it's a little bit out of date now, but this is a great review article listing all the possible things in play at that time. TNF antagonism was tried early on because for two decades people were going around the world saying, well, the muscle weakness must be a consequence of inflammation. That was probably a bit intellectually lazy, because when we looked for evidence of muscle inflammation in the muscle, we didn't find elevated levels of TNF, but that didn't stop people back in the day doing a trial of TNF antagonists in COPD. The trial was stopped early because of an increased proportion of malignancy in the patients who'd received the drug. And I suppose the lesson there is that the clue's somewhere in the name, you know, it's called tumor necrosis factor for a reason. I'm going to show you some data on myostatin, and there'll be people in the call who are probably familiar with myostatin, probably more familiar than me. Ghrelin agonism, there are 1 or 2 small studies. It hasn't really reached prime time, unfortunately, but certainly people have played with it, and they've also played with growth hormone. And then there is great interest in androgens, and there are 1 or 2 small studies with testosterone, but of course, now that selective androgen receptor modulators are available, that is also an area of interest. I'm sure most people know the myostatin story, but basically myostatin is a negative regulator of muscle mass. And the reason it was appealing to the industry was that for several generations, farmers by accident have bred double knockout animals. So this bull here is what farmers call double muscle because it has no myostatin. And there was a single case report of a human, I'll just show that on the right, where the baby was also excessively strong. And that made it appealing because it gave you a high degree of confidence that it wasn't otherwise dangerous to get rid of the myostatin. In the lower panel, you see Dr. Mann, who I don't think is on the call, in data from our patients, which studied in Dr. Kemp's laboratory. But you can see that the patients with the higher levels of myostatin tend to be weaker and have shorter walking distance, consistent with the idea that antagonizing the myostatin might be beneficial to the muscle. So we did a study, the reference is up there for anyone who wants to see it, not of a myostatin antagonist, although those medicines do exist, but of a blocker for the activin 2B receptor. And we do believe that there are other negative regulator of muscle mass that signal through the activin 2B receptor. So the patients received 2 doses of the monoclonal antibody 8 weeks apart, and the entrance criteria, and this is very important when you're thinking about studies, were either in terms of a low whole body mass or a low appendicular mass on DEXA scanning. And we had quite good success in getting the patients through this. It's often a lot worse than this in COPD studies, but anyway, we did it. And these are the results, and you can see that if you're allocated to the active drug, there's a significant improvement in thigh muscle volume, measured in this case using MRI scanning over a 6-month period. What was a bit more unfortunate, however, is that if I just put in the 6-minute walking distance numbers as well, there's not a clear trend in 6-minute walking distance. So we were undoubtedly able to grow the muscle, there's no question about that, but it didn't seem to translate to an improved walking distance. So how does it all work? For me as a clinician, I see strength as a sort of crumple zone, if you like. And so if you get a virus, and viruses are very fashionable these days, if you get a virus and you're strong, you're going to end up like the bloke on the left. But if you get a virus and you're not strong, you end up like the bloke on the right, because you don't have a big enough crumple zone. So to summarise, I'm very happy to take questions and show other figures, but is skeletal muscle a treatable trait? Well, yes, I think we can identify it with the short physical performance battery, and I've shown you data that suggests that has a link in directly to the muscle biology. Certainly, there's interest in delivering rehabilitation better. So around the world, provision is very patchy, particularly in the United States. Even in this country, uptake is variable because a lot of patients don't want to do it. And then we need to give more thought as to how you maintain the effect. And there are some very interesting studies going on now to try to do this with digital medicine and also with other forms of exercise. So I didn't, for reasons of time, show you our study, but we were able to show with colleagues in China, for example, that Tai Chi was equally effective as standard Western pulmonary rehabilitation in terms of improving exercise performance. So I think we do think low-cost rehabilitation strategies are appealing, and of course, at the sort of milder end, you need to start thinking about behavioural interventions against sedentarism, and again, there's a great deal of interest in this. And I do think drugs will come, but one of the problems is that there isn't a proper regulatory structure for this. So oddly enough, if you had a drug that made you walk further in COPD, then you couldn't get it approved by the FDA, even though you can get a drug that improves lung function approved by the FDA. So there's a lot of work going on around the regulatory side as well. And again, I don't think I've got them in my slides, but one of the things that several people on this call have participated in is an initiative called Proactive, which captures the patient's experience of physical activity, and that is now recognised as a validated outcome measure by the EMA, although not yet by the FDA. So progress is made, but the problem is it's very slow, and it may need one to retire before you actually see the fruits of the change. So on that note, I'm very happy to take questions, and if there are no questions, I can tell a funny story about the hat.